Hello! In this video, we'll become familiar with some peripheral vascular surgeries. These will include abdominal aortic aneurysm repair, angioplasty, bypass, graft procedures, carotid endarterectomy, insertion of an inferior vena cava filter, endovenous laser ablation, and vein stripping. Here we go. An aneurysm is an abnormal bulge caused by a weakened vessel and can form in any artery, but are most commonly found in the aorta. They can also be found in all areas of the aorta, but are more common in the thoracic or abdominal area. They are difficult to diagnose because they usually cause no symptoms. They may be found incidentally when the patient presents for other reasons. Small aneurysms generally cause no harm, but if the wall weakens enough to rupture, it can be fatal. Different types of aneurysms are based on their shape and/or location. Saccular aneurysms form on one side of the aorta. Fusiform aneurysms form symmetrically and usually involve an extended section of the aorta. A dissection occurs when the inner layer, or intima, tears and blood flows between the layers. The blood is contained within the outer layer, the adventitia, until it ruptures. Greater than 80% of patients with ruptured aortic aneurysm will die, versus 2 to 3% for elective repair of unruptured aneurysms. Type A dissections are performed by cardiovascular surgeons, whereas Type B dissections are performed by vascular surgeons. Aneurysm repair.
Our surgeon will perform an abdominal aortic aneurysm repair to prevent the rupture of a bulging area of your aorta. The largest artery in the body is the aorta, which is attached to the heart and receives blood directly from the left ventricle, or main pumping chamber. The aorta is divided into 4 parts: the ascending aorta, aortic arch, thoracic aorta, and the abdominal aorta. The abdominal aorta is the last and largest section of the aorta. It supplies blood to the lower regions of your body, including the organs in the abdomen and pelvis. The abdominal aorta ends around navel level, where it splits into the 2 iliac arteries that carry blood to the legs. The aorta has a thick wall so it can withstand the high pressure of blood being pumped from the heart. Over time, the wall of the aorta may weaken, slowly bulging outward like a balloon. When this condition occurs in the abdominal region, it is called an abdominal aortic aneurysm. Your surgeon will perform an open abdominal aortic aneurysm repair when the diameter of your aorta exceeds 2 inches, or if you're having symptoms such as intense abdominal pain or an abnormally prominent abdominal pulsation. Before the open procedure, an IV line will be started to provide you with fluids, antibiotics, and anesthesia. A traditional open surgical repair is performed under general anesthesia, which means you will be asleep for the duration of the procedure. A breathing tube will be inserted through your mouth and into your windpipe to help you breathe during the operation. When you are asleep, a catheter will be inserted into your bladder to drain your urine and monitor your kidney function. Your surgeon will begin by making an incision from the breastbone to below the navel. He or she will then locate the aneurysm and clamp the aorta just above and below it. Your surgeon will then open the aneurysm and sew an artificial graft, the same size and shape as a healthy aorta, into place. Your surgeon will stitch the wall of the aneurysm closed over the newly placed graft. The graft will reinforce the walls of the aorta. Your surgeon will close the abdominal incision with stitches. The total length of this procedure is usually 4 to 6 hours. Your surgeon will perform endovascular aneurysm repair, a newer, minimally invasive procedure if you have severe heart disease or are at increased surgical risk due to age or other medical conditions. Before the endovascular procedure, as with the open procedure, An IV line will be started to provide you with fluids and antibiotics. You may receive general anesthesia, or you may receive a sedative and an epidural, or regional anesthesia, to numb only the lower half of your body. Your surgeon will begin by making a small incision in your groin over your femoral artery. Then he or she will insert a guide wire into the artery and gently push it up toward the site of your aneurysm. A catheter or hollow tube will be passed over the guide wire and pushed toward your aneurysm. Using live X-ray pictures as a guide, your surgeon will pass an endovascular stent graft, a compressed fabric and metal tube, through the catheter to the aneurysm. Then he or she will open the graft, which will be held in place with metallic hooks and stents. Your surgeon may insert additional graft components to extend the graft into the blood vessels supplying your legs. Once the graft is in place, your blood will flow through it, not into the surrounding aneurysm sac, which will remove the pressure from your aneurysm. Finally, your surgeon will remove the catheters and close the incisions in your groin. The procedure will generally take 2 to 3 hours.
Arteriosclerosis obliterans means hardening of the arteries, and is a common disorder of the arteries characterized by thickening and loss of elasticity of the arterial walls, resulting in decreased blood flow. A type of arteriosclerosis obliterans is atherosclerosis, a disease in which plaque builds up inside the arteries. Plaque is made up of fat, cholesterol, calcium, and other substances found in the blood. Over time, plaque hardens and narrows your arteries, limiting the blood flow. It can lead to serious problems such as heart attack, stroke, and death. Major risk factors include hypercholesterolemia, cigarette smoking, hypertension, and diabetes. Atherosclerosis can occur within the coronary arteries due to a buildup of plaque which narrows the lumen. This reduces blood flow to the myocardium and can lead to angina or a myocardial infarction. Carotid artery disease occurs when plaque blocks this major artery supplying blood to the brain. This eventually leads to a stroke. Chronic kidney disease occurs as plaque builds up within the renal arteries, leading to a loss of kidney function. Waste and excess fluid builds up in the body. Peripheral arterial disease occurs when plaque builds up in major arteries that lead to the lower extremities and the pelvis. Common areas for early PAD are at the aortic bifurcation and the distal superficial femoral artery. Claudication or intermittent claudication is predictable pain experienced at the same point of exercise. As activity increases, the oxygen demands of the tissue increases, and pain is felt due to ischemia of the muscles. Once at rest, oxygen demands diminish and the pain subsides. Other symptoms include pallor, lack of pulse, and edema. Angioplasty opens blocked arteries and restores normal blood flow. It is done by introducing a spinal needle and threading a small guiding catheter into the artery. C-arm with contrast medium is used to visualize the lesion. A guide wire is inserted past the site of stenosis or blockage. At this point, a balloon angioplasty catheter is guided over the wire and the balloon is inflated to compress the plaque. A stent is then delivered to the site over the uninflated balloon catheter. The stent is expanded by inflating the balloon again. Stents are made out of stainless steel mesh, titanium, or polypropylene. The most common location for arterial obstructions due to plaque is the aortoiliac segment. Bypass graft procedures are another option for the treatment of PAD. The surgeon may harvest vein from the patient, such as a segment of the great saphenous vein, or a synthetic graft may be used such as Dacron or a PTFE. If Dacron is used, the surgical technologist must pre-clot the graft prior to insertion. Two types of bypass graft procedures for PAD are aortofemoral and femoropopliteal, often referred to as a FemPop. In a FemPop bypass graft, it is more common to use a saphenous vein from the patient's leg. If the vein is used in situ, a valvulotome is used to remove the valves so that they won't obstruct blood flow. If the entire vein is dissected out and reversed for anastomosis, the valves do not need to be removed. A thrombus is a clot that adheres to vessel walls. It may be either blood or atheromatous plaque. When a piece of thrombus breaks off and travels through the vessel, it is called an embolus. Other types of embolus are air and small pieces of tumor. It floats along in the bloodstream until it reaches a bifurcation or more narrow vessel and gets stuck. This blocks blood flow to the surrounding area, causing ischemia. An embolus that lodges within the arteries of the brain are what causes a stroke. We discussed in the last unit that this most often occurs in arterial bifurcations surrounding the circle of Willis. There are three main sources of emboli to the brain: pooling of blood within a diseased heart. An example of this is atrial fibrillation. Damaged endothelial tissue that forms on the heart valves, and this usually occurs on the left side of the heart. An atherosclerotic plaque originating from the carotid or vertebral arteries. Carotid endarterectomy is a surgical procedure used to reduce the risk of stroke by removing plaque from within the common carotid or internal carotid artery. Vessel loops and umbilical tape are used to isolate portions of the artery. The patient is heparinized prior to placing vascular clamps on the carotid artery. Because the brain also receives blood through the vertebral arteries and some other collateral blood flow from the carotid artery, blood flow to the brain is reduced but not completely stopped. Anesthesia will monitor the patient for any neurologic changes while the carotid artery is clamped. A carotid shunt may be placed when neurologic changes are noticed by anesthesia or when there is no neurologic monitoring. By inserting the distal end of the shunt into the common carotid artery below the plaque and the proximal end of the shunt into the internal carotid artery above the plaque, adequate blood supply is supplied to the brain throughout the procedure. The shunt can interfere with the surgeon's visualization and is not used unless necessary. To prepare the shunt, tie a silk tie in the center of the shunt and leave the ends long to assist with removal. The surgical technologist should flush the shunt with heparinized saline before giving it to the surgeon. Although it is not shown in the photo, it is common for surgeons to use a patch graft, either synthetic or vein, when closing the artery. This increases the size of the artery and substantially diminishes the chances of the artery from narrowing again. The patient is woken up from anesthesia while still in the operating room, and their neurological function is checked by asking them to squeeze someone's hand and wiggle their toes. The surgical technologist should ensure that the table is kept sterile until the patient has left the room. Several other treatment options exist for thrombus. Anticoagulant therapy in the form of warfarin or heparin may be used. Thrombolytics are another clot-busting medication that is used only in life-threatening situations because of the risk of sudden uncontrolled bleeding. Thrombectomy or embolectomy is another option. The patient is heparinized and vascular clamps are placed prior to removing the clot. A Fogarty catheter is advanced past the thrombus and the balloon is inflated. The balloon is slowly pulled backwards, bringing the thrombus with it. One other treatment option is the inferior vena cava filter, which we will discuss a little later. Pulmonary embolism is a sudden blockage of an artery to the lungs and is usually caused by a blood clot within a leg vein that is broken off and traveled to the lungs. Common symptoms include sudden shortness of breath, chest pain that gets worse when you take a deep breath or cough, and a cough that brings up a pink foamy mucus. Pulmonary embolism may be fatal. For pulmonary embolism prevention, the first line of treatment is usually anticoagulant therapy such as warfarin or Coumadin to try to bust up the clot in the leg. If that treatment is unsuccessful or the patient is unable to take anticoagulation drugs, an IVC or inferior vena cava filter may be placed. One type of IVC filter is called the Greenfield filter. It is percutaneously inserted under ultrasound guidance or may be placed in the OR via a cut-down. It is usually inserted via the left common iliac vein above the observed blood clot. If an embolus gets trapped in the filter, blood still flows around it until the clot can be cleared by either anticoagulant drugs, if the patient is able to be treated with them, or an endovascular catheter. Venous insufficiency is caused by incompetent valves in the leg veins causing a backwards leakage of blood flow. Blood pools and form varicose veins and can cause venous blood clots. Venous blood clots are classified in two ways by their locations: DVT, or deep vein thrombosis, or SVT, superficial vein thrombosis. Three elements that trigger thrombosis are endothelial injury, venous stasis, and hypercoagulability. Similar terms for basically the same condition are phlebitis and thrombophlebitis. Symptoms may include swelling, skin discoloration, aching, burning, throbbing in the legs and feet, cramping, weakness in legs, and a non-healing ulcer. A DVT has a high risk of breaking free and becoming a pulmonary embolism. As we discussed earlier, PEs can be fatal. Treatment of blood clots are systemic heparin and or warfarin, bed rest, and possible surgical insertion of an inferior vena cava filter to prevent PE. The treatment of varicose veins caused by incompetent valves has improved drastically over the past decade. Previously, the only option was vein stripping. Endovenous laser ablation is now performed in a doctor's office or clinic with minimal to no discomfort with just local anesthetic. The patient is able to return to most activities immediately. Nice legs, Dr. Cameron. This option, EVLA or endovenous laser ablation, is one option for venous insufficiency. Another is USGS, ultrasound-guided sclerotherapy, in which a solution is injected directly into the vein. Phlebectomy, or the removal of that vein, is also a possibility. Vein stripping is used less frequently because of these newer techniques. For vein stripping, an acorn stripper is inserted in the vein through an incision in the ankle to a separate incision in the groin. The vein is secured to the acorn tip, and then the stripper is pulled backwards, tearing and frankly ripping out the vein and turning it inside out. For a vein stripping procedure, the parameters will be all the way from the toes to the groin. So that concludes our lectures on the peripheral vascular system. I thank you guys for listening. I hope you all found it very beneficial, and go back and listen to any parts that you need to. Good luck studying peripheral vascular surgery. Bye guys.